Okay, good morning. Can everyone hear me? Let's see if I can disconnect this. Okay. Good morning and welcome to what we hope will be a very fruitful and spicy discussion. Our topic this morning, can universal health care solve cancer care disparities, is a little bit of a embellishment or focus on what the original debate topic was, because please remember that we're all here for discussing how to address and solve cancer care disparities. I wanted to lay a little bit of a framework, since this is a very broad question, and then we'll introduce our panelists and start our debate. I don't need to stand up here and tell this audience that the bang for the buck in the US healthcare system is not really there, and we're notorious for this across the world. I'm not going to belabor the point, but just share a couple of images where we see that we spend a lot and we don't get a lot. Life expectancy versus healthcare expenditure has one notable outlier, and that is the USA. When we think about cancer, however, America brings a lot of hope to the world. We have a very comprehensive ability to screen people for cancers and catch a lot that way, and then even within and outside of our country, people travel. People hold out hope until the last moment that they will be cured if they come to America. The American healthcare system is centered on a free market and private sector model. In 2003 and 2009, we actually had two pieces of legislation, the Medicare Modernization Act and colloquially the ACA, that made some major changes. However, America was very afraid of universal health care. None of these were described as being universal health care. Why? Where was the fear? Increased wait times, threats to pharmaceutical innovation, hampering competition, and the fear, most of all, that this could limit free choice somehow, that having rationing, having one source of healthcare was going to hurt people. I offer you what is happening in cancer care today. The cost of cancer medications is astronomical. These are just some examples for the sticker shock. I'm sure we'll get into it. What happened to the sources of Americans' fear? Is American care for a fatal illness falling short of our expectations? Wait times. We have a huge disparity in access across the country. If you live at the foot of a NCI-designated comprehensive cancer center, that's great. If you live 6 hours away, not so great. We were concerned about pharmaceutical innovations. Cancer drugs can bankrupt families. Competition. In the last 15 years, we've seen hospitals and providers consolidate more and more, and the effects of this on access and on prices are of high concern. And then when we talk about free choice in cancer, cancer is one of those diagnoses that we feel still can fall on anyone. In the last 15 years, we've seen more young adults be diagnosed with cancer than ever before. We're seeing what is sometimes referred to as a silver tsunami, as the baby boomer generation reaches the ages that have peak cancer incidence. There are a lot of people who may not have thought of themselves as folks who would get cancer that are suddenly going to be confronted, whether they've made choices or not that lead to it, with a diagnosis that is life-changing. So what could cancer universal healthcare look like? We're going to ask our panelists to share their thoughts or their views so that we're all working from somewhat of a common ground. I just wanted to share a couple of thoughts that are out there in the literature. Universal healthcare can be thought of comprising three dimensions. This is actually from the American Cancer Society's Cancer Atlas. The proportion of the population covered, the proportion of prepaid funds and reduced out-of-pocket payments, and the number of services available to the population. Even within this definition of universal healthcare coverage, there are different ways that these three levers can be used. When some people say universal healthcare and think of single payer, they're thinking of the model on the right, the UHC approach to cancer care, where you have more people in the population covered and that's the priority. On the left, we have the advanced services approach to cancer care, where you have more costs covered and more advanced services covered. I would argue that's what America excels at. More technology, more innovation, but not necessarily a change in the population coverage. Both of these could be said to be a form of universal health coverage, and we can debate which one of these is more effective for disparities. What else do we know? We know that nobody has really figured this out yet. This is a topic of international discussion, and it's okay. That makes sense. We're almost done. It's a topic of international discussion, no one has a silver bullet. Globally, many ways to cover cancer care. In the UK, there's the Cancer Drugs Fund, which was an addition to the NHS coverage to combat the fact that cancer drugs are very expensive. You can ask folks there whether it works well. You'll get mixed answers. We have approaches that talk about the price of drugs, access of drugs. Here in America, we have our own VA, Veterans Affairs medical system, that is looking beyond drug coverage to figure out more about how to provide actual services consistently to veterans. So there are many, many ways to do this, and we can talk about all of the options. Fundamentally, we have to decide as a country what we are going to say to patients and families who fear the deep personal loss and major life disruption of death from cancer. Those promises then have to be backed up by the reality of our healthcare system. And that's the challenge that I want to offer to our panelists today. We have, we're very lucky to have very experienced folks from the health policy world. These are influencers, people who sit at positions of organized medicine and policymaking that have the ability to shape our healthcare system into something that we want and something that we are not ashamed to offer to our patients when they have a diagnosis of cancer. So I'm really looking forward to hearing what they have to say and hearing them convince each other of what our next steps should be. So with that, I'm going to invite our panelists to stand and to use the stairs on the side to come on up. You can see your names in the lectern, so if you get in relative order, it'll be easier for you. And while you're doing that, Dr. Goodman is going to introduce them.
Thank you. I'll let everyone get up here. Yeah, so in the next hour and a half, we're going to finally solve universal health care and come to a solution, hopefully. So. Okay, I'm going to briefly introduce our all-star panel up here that's dedicated their time to come debate this really complicated issue. So thank you for coming. So first I have Dr. Karen Knudsen. She is the CEO of both the American Cancer Society and the American Cancer Society Cancer Action Network. She's an internationally recognized leader in this. Next we have State Senator Manka Dhingra. She's the Deputy Majority Leader of the Washington State Senate. She brings 2 decades of experience as a prosecutor and a behavioral health expert to her role as Chair of the State Senate and Justice Committee. Welcome. Next we have Dr. Barbara McAneny. She is a practicing hematologist-oncologist from New Mexico, and she's co-founder and CEO of the New Mexico Oncology Hematology Consultants. She also is the former president of the American Medical Association and has served on the AMA Board of Trustees from June 2010 up until 2016. Welcome.
Thank you.
Next we have Dr. Willie Underwood. He's a recognized health expert in care disparities in health policy. He's also board and chair of the American Medical Association. Welcome. Next we have U.S. Representative Adam Smith. He's a congressman and represents the 9th District of Washington State, serving parts of Kings County, including Seattle, South Seattle, Renton, Bellevue, and Federal Way. Welcome. He's been serving on the Congress since 1997. Next we have Dr. Isaac Opole. He is the president-elect and member of the Board of Regents and former governor of the Kansas chapter of the American College of Physicians. Welcome.
Thank you.
Yes, and I want to remind the audience also that they can turn in questions. We'll be circulating them. They can write it, and they can be anonymous or actually give their name. It's their choice. I'm next going to go over the debate rules. Okay, so questions will be directed to an individual panel member. The member has 2 minutes to answer the question. At the moderators, at our discretion, there will be time allotted to 1 response, perhaps 2 or 3 if people are really getting into it, from a different panelist, and they will get 1 minute to respond. For panels, for questions directed to the panel as a whole, they will have 2 minutes to answer the question, and then there will be 1 minute to offer a response.
I actually changed the rules this morning, and I went over it with them already. For this section that is, I think you were in earshot. To make sure that we have enough topics that are going to be covered by this group, when we get to the free-for-all section where we're really debating, we're going to give each panelist 90 seconds to talk. But that's it. The rest of the rules stand the same. Just to say, we're going to do questions on paper. You can put up your index card. Someone will come collect it. Or you can tweet them at either of us or at the BT Foundation Twitter handle. And we will be collecting those questions electronically, and we'll be working them into the second half of the discussion. Sure. All right. It is, let's see, 9:13 a.m., and we're going to start Section A. So for the first section, we're going to go down the line, and we would like you to offer us a definition of universal health care and how you believe that this definition would impact cancer care disparities, and impact can be positive or negative. You're going to have 2 minutes to respond. There are no responses in this section, and we'll start at the first person.
Oh, okay.
Yeah.
All right. Well, I might be the spoiler in this. So let's see. So I'm Karen Knudsen. I'm the CEO of the American Cancer Society and also ACS CAN, which is our 501c4 advocacy affiliate. What that means is that we can and do lobby, and that we work with elected officials on behalf of the stakeholders that we represent, cancer patients and their families, at the federal, state, and local level. So we think really deeply about this issue. When we look at healthcare, I think we all agree that it's not meeting the promise for cancer patients or their families. It's heavily disjointed, and that what we owe to cancer patients and families is a seamless healthcare experience across the cancer continuum that allows an integrated system of care so that they have every opportunity for the best outcome. That's what I would describe as the ideal. And I know that the prompt is, what does universal health care look like? I am a product of universal health care. I grew up in a military family where everybody had care. We were all on the same records. No one paid a dime for anything, a drug, a service. And so it was a shock to me, as I became an adult, to realize that that was not the experience of the average individual in America. That said, I do not believe, as much as I think that universal health care is an important goal, I do not believe that there is political will and that we are ready for it. So I'm much more of a ground shot, not moonshot person. And so we think deeply about what is our ground shot and what can we do right now. 5 things. 1, expand Medicaid. 2, enhance access to patient navigators through reimbursement. We've worked very hard on that in the last year. 3, address medical debt and the impact on credit for individuals with cancer. 4, extend the ACA tax credits. And 5, remove barriers to clinical care. Clinical trial, sorry. Thank you.
Good morning, everyone. My name is Manka. I'm the state senator from the 45th Legislative District here in Washington. I sit on the healthcare committee and have been for the last 7 years. That was very impressive timing, I gotta say. You know, I think I am that politician who still hopes to get to universal health care. And my definition is exactly what you described growing up. And that is making sure every single person in our society has access to high quality health care, regardless of their ability to pay. I think that is the goal that we want to get to, really understanding that healthcare should be a right, not a privilege, that people don't need to go into bankruptcy because of medical debt, that we're seeing happen in our society over and over again. And I do think Washington has made, this Washington, I call this the good Washington. I think the good Washington has made a lot of strides in trying to get to that. And I will say there is a lot of political will here in this state to have us on a pathway where we can achieve this dream. I am really proud that the work that we have done, our uninsured rate is now at 4.7% in the state. So yes, there is political will, and I think there's some of us working really hard to get there. Thank you.
Thank you. I'm Barbara McAneny. I am a medical oncologist, hematologist in Albuquerque and Gallup, New Mexico, where our clinic serves some advantaged patients and some very disadvantaged patients. So I would define universal health care as the ability for a patient to access the care that they need at the time they need it, where they need it, and when they need it. so that they do not have to pay more than about 6% of income. And if you're poor, I think it should be less than that because that's such a burden. I also think that patients should have the right, we don't currently, but we should have the right to get the care from whom you wish to get the care, and to have it be respectful of your own personal values and culture. I also feel strongly that any healthcare system that requires a navigator actually should be replaced with a healthcare system that does not require a navigator.
Wow, man. Hi, I'm so glad to be here. This is awesome. Okay, I'm that guy. All right. Okay, so I'm the chair of the board of the American Medical Association. So the AMA believes that enjoyment of the highest attainable, sustainable health is what we're trying to achieve, right? So that's what we're saying. We're just asking the question if universal health care gets us there, if Navigator gets us there, if having 6% gets us there, right? So if we focus on where we're trying to go, then we can get to the place that we're trying to achieve. So the question is, does universal health care get us there? So in our view, the ability for everyone to access meaningful and affordable health care coverage that they can have for top quality care, like Barbara said, get it from the people who they want to get it from, right? Get it from people who are part of their community, who works with them, who want them to have one great outcomes, right? So how do we get there? How do we get there? So I know that people who lack insurance are more likely to not access the system, the timely manner in a way that they can reduce their life, right? Improve their quality outcome. Make sure that they have the outcomes that we desire for them and that their family desires for them. So we have to address social determinants of health as well, not just having an insurance card, but having the ability to get there through transportation, through housing, to education. All those things must be addressed as well. We must build a system that has a foundation that works for the people. We must make sure that the system works for the poor as it does for the rich, right? The poor as it does for the rich. Because right now, why, they did a study and they asked this. They said, why are you, 10 seconds, why are you on the board of a hospital? And you know what the board member said? So I can have access. Thank you.
Well, thank you very much. It's hard to add to what's already been said, but I think we need to also, as we engage in this discussion, first of all, understand what we mean by health, what we mean by health care, and what we mean by health care coverage. Those should not be conflated. Health is wellness. It's a human right as defined by the World Health Organization. The American College of Physicians just released a paper last December that defined health as a human right. It is the first part of our Constitution. The right to life equals health, liberty, and the pursuit of happiness. Health care is a suggestion that resources need to be placed for health, okay? It is the person standing by your bedside, the medications that you're using. Healthcare coverage is who pays for those resources that get employed in providing you health. So we need to be very careful how we define these terms and not conflate the terms. Health and health care, I believe, is a goal for us all. Healthcare coverage is a societal discussion that we need to have. Now, the American College of Physicians sees health as a human right and considers access to quality, patient-centered, accessible, and equitable care for all persons as a cornerstone of what we would call universal health care. As a moral society, we must also be conscious that cost is an issue, and the cost should be bearable by both the individual and the society, so we shouldn't be cost illiterate. But the American College of Physicians released a series of position papers in 2020 that basically said better is possible. We can change how we structure healthcare service provision. We can change how healthcare services are paid for, the concept of coverage, and we can ultimately produce better results for our population. If you look at developed countries around the world, Sweden, Germany, Japan, Norway, Switzerland, all of those countries have better healthcare outcomes than we do, even though they spend less than half of what we spend.
Thank you. I think universal access to health care means everybody having access to affordable basic health care. And, you know, I support the Medicare for All plan. There's a variety of different plans that make sure everyone's covered, which, of course, we don't have here. We have a patchwork. But the one thing I'd like to add to this discussion is the problem of cost. And when you think about health care, the easiest way to frame it as a starting point is to understand that the demand for health care is way crazy higher than the amount of money available to pay for it. And at the end of the day, as policymakers, that's what we're always struggling with. And what I hope we'll think about in the U.S., as the gentleman just mentioned, we spend more money than any other country in the world, and yet we don't get the results. But we don't spend a lot of time talking about what are we currently spending money on that we shouldn't be spending money on. Okay? We can all talk about, well, we don't pay for this and we don't pay for that. We're already paying more than anybody else. We're already, you know, it's really, really expensive. What about our system is different than these other systems where we spend a lot more money? And I'm sorry, if your definition of healthcare access is each individual patient gets to get whatever healthcare they want, whenever they want it, from whoever they want to get it from, you may as well go ahead and declare bankruptcy right now, because it's just not going to work. That's not going to happen, all right? Most of these other countries significantly restrict what they pay for. And I'll just throw one provocative thought out for you. We spend more money on end-of-life care in this country than any other country in the world. And we're talking tens of billions of dollars, okay? So as we're all excited about universal access to health care, what if we also said, guess what? Yeah, we're not going to spend as much money on end-of-life care. And for the moment, by the way, I'm not making a judgment whether that's right or wrong, all right? But that's one of the things we do in this country. We spend an enormous amount of money on that. Are we willing to make different choices? The thing that we lack the will to do in this country is to make those kind of choices. And I believe me, I don't want to make that kind of choice. But if we're going to build a successful healthcare system, we have to make some of those cost choices that are brutal and hard and difficult. And I hope we'll think about that as we're building a universal system.
Well, thank you. That was wonderful. So we're going to move on to the next section where I will be asking individual questions to each of you. And again, responses are allowed. You'll get 2 minutes and then 1 minute responses. Okay. The first is for Dr. Knudsen. So considering your leadership in cancer care, how could universal health care impact the outcomes for cancer patients, especially in terms of early detection, treatment accessibility, and survival rates? And I would also like you to comment a little bit what the congressman was discussing. I mean, I give $1 million therapies sometimes close to the end of life, and the amount of money that we're spending in cancer drugs, while certain aspects of cancer care I can't get funded, including sometimes even transportation to the cancer center.
Yeah, so I'm so glad that this was brought up. So, you know where I stand. I'm going to, again, ground from the perspective of ground shots, things that we can do based on what we have right now. We will not be able to afford cancer care for everyone and universal cancer care unless there is a shift to prevention and early detection. That is not something that even the way that we're currently structured in the reimbursement area is dedicated toward, but we are inching toward that. So what are some gains that we've had? Example, January 2023, it became that we eliminated as a country the cost of colonoscopy, follow-on colonoscopy for someone who tested positive at home with stool-based testing. What were we trying to incentivize for? Ensuring that that individual got screening and an early detection that allowed there to be a lower cost of care, higher level of survivalship. Again, policy and advocacy can get people into early detection. January 2024, patient navigation reimbursed as a component of cancer care is one of our biggest stretches and goals. Why? And I actually don't believe that anybody who doesn't have a navigator shouldn't have a healthcare system. Here's the fact.
No,
this is just
that's not what I
data.
said.
Patients who are navigated understand their care, they complete their care as planned, they have a better outcome. They also don't land in the emergency department, which is high cost, low efficiency care. All boats rise. So there are many all boats rise opportunities for us to shift into prevention and early detection. And the last one I'm going to talk about, and you can feel however you want to feel about Medicaid expansion, but we've done the experiment 41 times, 40 states and the District of Columbia. And what happens after you expand Medicaid? People get into screening and early detection, survival rates go up, and the cost of care goes down. So I very much agree with the congressman. We have to address cost, but it has to be through shifting to earlier disease course.
Any responses?
I would like to respond to that. So I think we have plenty of money in healthcare. I think it's all going to the wrong places, or most of it is. The only way to not make money in healthcare is to ever put your hand on a patient. We have a healthcare system that is perfectly designed to make large corporate entities, large consolidated hospital systems, large consolidated insurance industry, et cetera, a lot of money. And if we could redistribute that money, we would be able to do much better. Running a practice in the area that I do with a hospitalization rate of 60% of the national average, I think navigation should be hardwired in. I'm not opposed to helping patients get through the healthcare system that we live in, because no one who's sick can possibly do that on their own. However, I do think that the goal is to restructure the healthcare system for that.
Okay, this next question is for our lawmakers. So I will ask, so from a legislative standpoint, what are the main barriers to implementing universal health care in the U.S., and how could these challenges be addressed to ensure equitable access to health care for all?
Okay, since you're looking at me, I'll go first.
Yes, you go first.
You know, there are tremendous challenges to get universal health care. I think a lot of what you just heard about the profit motivation in the healthcare industry is a huge component of that. And I will say again, you know, in 2013, the uninsured rate in Washington state was 14%. And now, as I mentioned, we are at 4.7%. And so the question is, how did we get there? It's expanding coverage. It's making sure that we implemented the Affordable Care Act effectively. We made sure we have better coverage through Apple Health, which is our Medicaid program. And we created the Washington Health Benefit Exchange. Cascade Care was the nation's first public option for health care coverage in the state of Washington. That's what we called it. And we also had to make sure, however, that we offered subsidies. And in order to get to universal health care, we all know this, you have to get more people into the insurance market and you have to make it affordable. And the only way we could get to the 4.7% uninsured rate was to actually have a lot of the subsidies that we currently have and leverage that with the federal subsidies that are currently available. But the biggest challenge is we need partners at all levels to do this work. Our federal reimbursement system incentivizes not prevention care. And we have to make sure that the financial incentives in this industry is about prevention and early detection. We still have a system where there are doctors that are compensated more if they do more surgeries and procedures. And if they don't, their paycheck actually reflects that. That is a model that currently exists in this country, and that is a problem.
Yeah, first of all, I think the absolute right approach is try to expand coverage as best as you can. That was the principle behind the Affordable Care Act. I think it made an enormous difference. But look, the barriers to getting universal access are, number one, the profit motive, without question. They want the freedom to do that outside of a controlled system. So, gosh, should we have for-profit insurance companies? Probably not if you want to get to a better healthcare system. And so the profit motive is a big one. But the second biggest one is the insurance that people do have. We have an employment-based insurance system. And if you want to do a universal access to healthcare system, the only way that works is if you take that insurance away from some people. There are some people, tens of millions of people in this country, as a matter of fact, who have really good insurance. And they don't want to give it up for something that might come. So how do you get around that? You can't have both and make it work. So those are two of the biggest impediments. The other thing is universal access means everyone has to be insured. You cannot individualize the entire healthcare system and have a universal system, okay? We ran into this with the Affordable Care Act. Everybody has to be covered. Well, I don't want to be covered, okay? I want coverage when I need it, not when I don't. Well, insurance doesn't actually work that way. In order for insurance to work, some people have to be paying more into the system than they're getting out of it, which means healthy people need to buy into it. But we don't want to do that because we want the individual freedom, and everybody screamed bloody murder about it. And the final point is when it comes to picking treatments. You can't just leave it up to the doctor and the patient because the doctor has incentives. as you mentioned with the surgery example, which I 100% agree on, having gone through 2 hip replacement surgeries that I may or may not have needed, and a 3rd surgery that I definitely didn't need, really important. And the patient's going to want whatever they want. How do you control costs? And we had that in the Affordable Care Act. We had a system, and oh my gosh, it was, what did they call it? It was the death panels, if you weren't just giving people what, so we are resistant to that, which makes universal access very difficult.
Any comments from our panelists?
Can I jump in?
Yeah.
Yeah, I think these are really important points. I just want to ground us in a little bit of data and level set, where are we right now? So if you poll individuals who are uninsured in the US right now, didn't take advantage of ACA to the point of who needs to be insured, 64% of them, and this is the non-elderly, say that the reason that they didn't do it is because of the high cost. So we have to make it in a way that's adjustable. But also, I think it's important for us at this conference to look at who's being left out. So we have now 7.7% of people who have not insured, 7.7% of people are not insured in this country at this moment. That's about 25 million people. But who is it affecting? It's 1 in 4 Hispanics in the United States and 13% of the black population. So while that 7.7% seems really small, it's not affecting everyone equally. And so I think that's one of the things we have to keep in mind as we're thinking through some of the solves that you're talking about here.
Any other comments?
I'll comment on that if I can. The access to health insurance is not access to health care. We have a significant physician shortage in this country. And if we are going to solve that, we have to understand that the money has to be there. New Mexico has 48% Medicaid. So I live in Medicaid expansion, and Medicaid pays about 75% of my costs of delivering care, not what I charge, not what the insurance companies pay me, of what it actually costs me. So if I cannot cost shift into those Medicaid populations, and Medicare, by the way, pays about 80% of my costs in my state. And this is because we have things called the geographic price cost indicators, which have set up Medicare to be different in different parts of the country. So if you happen to live in a country where it doesn't cover your costs, and you don't happen to have a population that can pay more into the system, you are not able to maintain a practice. To maintain a practice means keeping the lights on, paying the nurses, paying the doctors, and it is not sustainable unless we have a system where the coverage is there. And that's my problem, frankly, also with Medicare for All.
Dr. Opole, he really brief.
Yes, I'll be very brief. The American College of Physicians, the second largest physician organization in this country after the AMA, actually stands behind a single-payer universal health care system. During the debate for the Affordable Care Act, they were behind a proposed single-payer system. Number 2, for your extra hip replacement that you did not need, physicians don't want to be doing that. Physicians do not want to be paid for widgets. The American College of Physicians also recommends payment reform so that your physicians are reimbursed not for widgets, not for hips taken out, but for patient quality outcomes.
Yeah. We'll go back to Dr. McAneny. Given your background in running a cancer center, what operational and financial challenges do healthcare providers face that universal healthcare might solve or exacerbate?
Well, remember that we have 18.6% Medicare in this country and 18.5% Medicaid, only 54% of the country, and I wish I had 54% that had commercial insurance that actually pays with a margin in my state. Medicare is a problem because Medicare does not cover the total costs. Medicare has a lot of advantages in that patients can go anywhere they want. However, to have Medicare, fee-for-service, you have to have Medicare, a Medigap, Part B and Part D, and about 2/3 of bankruptcies still occur from a healthcare event, and 2/3 of those people have insurance. Now they've switched to Medicare, what I call Medicare disadvantage, because that takes away all the premiums, so it's zero, but then they sneak in lots of various things. It's become a cash cow for pharmacy benefit managers all across the country who are now Fortune 5 companies, think Optum, Caremark and Express Scripts, who own 80% of the prescriptions written in this country and make money 7 different ways from each of those. We need to get rid of that. And the Medicare Disadvantage programs advertise heavily 0 premiums, free eyeglasses. And that really takes advantage of the people who are least able to afford an expense when they have. And then they put in things like when you need that cancer drug. And as a cancer doctor, when somebody needs that drug, they need it. When you can't get it because they discover that your Medicare Disadvantage has put a 20% coinsurance on your chemotherapy or has removed all of the new drugs, the expensive drugs, which are actually the good ones, not only for cancer, but multiple sclerosis and rheumatoid arthritis and inflammatory bowel disease. Remove those so that you are functionally non-insured, and then expect practices like mine to pay financial counselors, to find free drug, to try to help these patients out. So we have a lot to fix in this system, and Medicare for All is not the answer for that.
I would respond just quickly on that. Medicare as it currently exists, certainly not. You'd have to build off of the system. But that gets back to what I've been harping on throughout this conversation, and that is, where are we spending money that we shouldn't be spending money? I mean, the reason that Medicare only pays 80% is because they're trying to survive. I mean, they're scheduled to go bankrupt at a certain point. So what could we look at within that system and say we're not going to pay for this? And then you could have greater savings, and there's a bunch of different options. You know, Medicare for All is just basing it off of an existing system instead of trying to build a brand new one. I mean, who's to say that a brand new universal access system wouldn't have the same problems? Okay, you know, you may as well build it off of a model that we have, but you do definitely, without question, have to make changes within that model, no doubt.
Can I just jump in really quickly? You know, I've been a prosecutor for 20 years before getting into politics, and I started the Therapeutic Alternative Unit, which is really taking a look at mental health, substance use disorder in the legal field. And the way I learned about Medicare and Medicaid was Medicare, we care but not really. So yes, that's how lay people learn about these things. And so we have to change what Medicare looks like. We have to change it in a way that makes sense and is effective. And this is where taking a look at what Washington has done with the healthcare exchange and creating standardized plans is really important, because then you have consistency on what the plans are supposed to cover if you have a silver plan or a gold plan. And this is where you take a look at consumer protection as well, because when you have 30 plans to choose from, the layperson really does not have a way of clearly identifying what is a plan that's a good fit for them. So really making sure you have standardized plans that people can pick is a huge advantage.
Okay. Yeah, I mean, just to add, I mean, what are we not going to, you know, where are we spending our money? You know, we have in our guidelines drugs that don't benefit patients that cost $50,000 a month. We have advocacy groups advocating for them. We have end-of-life care, and patients want this. And you know, I mean, I leave it to you guys, policy experts. How are we going to rectify this? Really, anyone can comment on that. But we, as physicians, we are incentivized to see more patients. We are incentivized, some of us, for procedures, for scanning. Again, in our guidelines. And I don't have a solution. Hopefully, one of you do.
Well, I don't know if I'm the only one here who's been involved in value-based care. But,
no, you're
you know,
not.
and I'm going to take off my ACS hat for a minute and be a former healthcare executive running oncology for a 16-hospital system across 2 states. We did take one of our sites, our main academic site at the Sidney Kimmel Cancer Center at Jefferson, and enroll in the oncology care model. And we are one of only 1/3 that enrolled in OCM who actually saw benefit savings. Now, for me, as the head of cancer, it was really illuminating to be able to see for the first time, based on the dollars that were given to us, in part paying through navigation, how it is that the services provided lined up with quality, and then what adjustments we could do. So I obviously value-based care is going to happen at some point in time. What that looks like, I think, probably will be part of this solution.
And if I could just
have to comment on that as well,
Sorry.
because in 2012 I had a Innovation Center Award called Come Home Community Oncology Medical Home, We saved $667 per patient during the course of chemotherapy. My hospitalization rate is 60% of the national average. We saved $4,000 a patient for end-of-life care because patients knew that we would be there for them. So value-based care and the oncology care model came out of my Come Home Innovation Center thing. So I probably agree, if you have a 16-hospital system, you probably do need a navigator. But if you have a community practice that is there where the patients need to be, then we do the navigation for them. And we built our practice based on the idea that the well people take care of the sick people, and we navigate for them, and we make sure that they get what they need. But they understand what they need when you take the time to educate and to talk and to do all the things that are essential in that.
I think RVU models make it really hard to have that discussion.
If I could, on the, because what we need to do is really kind of simple, and that is, pay for quality instead of quantity. And contained within the ACA, there were a dozen different ideas for how to do that. And there were a bunch of little pilot programs that did that. The problem was that the profit incentives and patient demand, every time that quality thing said, well, no, this is quality. So, well, no, wait a second, I like this. Okay, you can't deny me that. I have my individual rights. So I'm going to insist upon this. And then, of course, the people making money off of it got really aggressive about marketing it. Yes, we should not have advertisements for drugs. I joke that, or at a minimum, can we ban them from being allowed to have jingles to advertise their drug? Can we not be dancing around to like some sort of play to decide what cancer drug we're going to take? All right, so you need to make those choices. But what stopped us from being able to implement that, and I really want to emphasize it, the profit motive of, yes, some physicians, some, certainly drug companies, insurance companies, and individual patients who would say, no, you can't deny. We have to have everything or it's not fair. We have to make choices to get to quality over quantity.
We have to move on, but I'll let you speak, Dr. Underwood.
All right. As you surmised, there's nothing about this that's simple.
Amen.
Right? Nothing. This is a complex, complicated thing. And I'm going to throw some monkey wrenches in here. I'm a surgeon, and I would hate to be put in a position where I have to operate on someone just so that I would get paid through an RVU. That's sick, right? I would also hate, if I ever had a patient of mine or the thousands I've operated on, to ever sit and say, I'm not sure that the surgery that Underwood did that I needed. That would hurt me. That means that I didn't do my job as a doctor to educate them, to walk them through the process. Secondly, tell you a quick story. Viagra. Advertising, boom, 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 boom. What did Viagra do? Yes, men came out of the woodworks talking about erectile dysfunction, but we also diagnosed diabetes, hypertension, put people in smoking sensations. So when we sweep these things and say these things and sweep them, we understand that there's also negative consequences to that as well. So we have to truly take a step back and say, what are we trying to accomplish? And what system do we need to put in place to make that happen? If physicians can't afford to take care of my grandmother, then my grandmother won't get the care she needs. That doesn't make any sense. Thank you.
And the AMA did try many years ago to block the pharmaceutical advertisements on television. We took it to court and we lost as a First Amendment right.
Thank you.
We will move on, but a great discussion. I mean, we could have a whole another debate on how do we define and measure quality in medicine. I mean, clearly our FDA doesn't monitor that. Okay, next, Dr. Underwood, what impact could universal health care have on preventive care and public health initiatives, particularly for underserved populations?
Man. Okay, so preventive care plays an enormous role in helping people. We've all said that. The ACA expanded the opportunity for that. People being able to get reimbursed. We also have to make sure that the reimbursements work, that we have an infrastructure that allow us to provide it. So it's great if you're, as originally said, that if you're at the base of a comprehensive cancer center, but what if you're 60 miles away? You should be able to get the same quality care that you get at a comprehensive cancer center, right? So these sort of things. So the AMA, we're all involved with the ACA. We supported it. We expanded it. We have to expand Medicaid. I know I'm running out of time, but I'm not sure that a single payer does it, right? So again, I keep saying we need to step back, think through, focus on our goals and what we're trying to accomplish, and not have conversations about whether or not it's a single payer, whether or not it's expanding Medicaid, whether or not it's this. It's like busing, okay? No one ever asked the question, how do we educate every single child in America so they become a productive citizen? We argued about busing, and now we know our health educational system sucks, and our healthcare system will continue to suck if we keep talking about single payer, expanding Medicare, and not how do we improve the health of this nation. Thank you.
Can I add some comments?
Can I jump in here with the concern that probably everybody should be aware of, that we watch very closely, and that's Braidwood versus Becerra. So, you know, right now ACA did significantly expand the ability of individuals to get to preventative and early detection care, bringing it again back to cancer. So that is significantly under threat with Braidwood versus Becerra. If it goes the other way and reverses where we are right now, I would expect the private payers to once again start to put financial barriers for individuals to go for preventative cancer screening. And that will be a challenge. I think my point of view is that will pull us far away from what everybody here just talked about, which is addressing cost through shifting to early disease state.
I would agree, and I'll add on with that I definitely am on the same side for that. Even when you say it's free, people don't believe it. My practice through our foundation did a free lung cancer screening, and we screen about 50 people every 6 weeks on a Saturday on a CT scanner and find a lot of disease because it's free. I cannot do that out of my practice because that would be inurement and I would go to jail. So I do it through my foundation. And so this is one of the many self-inflicted wounds that we have created in healthcare. We all know that healthcare is more expensive when people have less ability to take care of themselves, yet we pay physician practices and hospitals less when they are in underserved area because we build our healthcare payment system on geographic price cost indicators, apartment rent, and non-farm labor in the area where you work. That is backwards. That is something that could be fixed immediately. If I were constructing a healthcare system, I would pay people more to work in underserved areas. I would pay physicians more to work in these areas. And I would take the money to balance the budget. I would take it out of pharmacy benefit managers. I would take it out of large corporate entities. I would take it out of large hospital systems because if a person gets cancer care at a hospital, it costs 160% for the same drug, and it costs double to 5 times as much if you're on a commercial plan. So we need to focus the hospitals on acute care business, taking care of people who need emergency departments, complicated surgeries, or who have problems from failure of the chronic disease management system to manage those diseases properly. And we need to move the chronic disease management back into the communities and small practices that can work directly with patients.
If I can add on to some of that, what we've been talking about for the last maybe 10 minutes is really payment. Who's paying, whether it is Medicaid, Medicare, Medicare for all, single payer, insurance companies. The issue here is payment. And one of the issues around payment is the question of cost. In the healthcare cost universe, the only piece of the healthcare cost equation is the physician payment, which by Medicare rules has to be budget neutral. It's the only piece of this equation that is budget neutral. Pharmaceutical companies can't charge anything they want for anything. And that's the other piece, that the biggest payer, the biggest consumer payer for healthcare services is literally barred by law from negotiating the prices of those drugs. And when the Biden administration recently passed rules allowing for negotiation for drug prices from pharmaceutical companies, certain pharmaceutical companies, Merck, for example, immediately sued because they don't want the government to negotiate for drug prices. Those of you who are aware of drug prices in other countries know that on average, the American patient or the American healthcare system pays 10 times, 100 times, sometimes 1,000 times for the same drug manufactured by a US-based company in other countries. We paid 100 times more for Gleevec, for example. than folks pay for it in India. So the question about cost also needs to be looked at. Why is it that physician reimbursement has to be budget neutral? If a primary care physician is to be paid more, a surgeon must get less, while pharmaceutical companies can charge whatever they want for whichever drug they choose.
Okay, we're gonna stay with you.
Can I make one comment?
Yes, 30 seconds.
All right, this is simple. Barbara's right, but she wouldn't get elected because that would be such a political nightmare conversation. That's great. One debate, she'd be gone.
All right, so we'll close out this section with Dr. Opole. So as advances in clinical medicine become more complex and primary care providers have more on their plates, how can specialists and PCPs evolve their interaction and co-management of complex patients such as those with cancer? How would universal health care coverage aid or hamper co-management, especially across geographic borders?
Yeah, the ideal way to care for patients, cancer patients in particular who are really complicated, but also other patients, is by having a seamless and integrated care system where the patient can move from one level of care, one source of care to the next without there being barriers. Right now, the healthcare arrangement that we have, I wouldn't call it a system because we don't have a system. Right now, the arrangement that we have is a hodgepodge of independent financial entities that are all trying to make a buck. The primary care physician, the oncologist, the cancer medication provider, the cancer center, the hospital that has the patient, that does the biopsy, the operating theater, the lab, all of those are profit centers for individual elements. They are not unified and they're not coordinated and they do not by any means constitute a system. What we need is a healthcare system where the primary care physician and the oncologist work in concert at the cancer center with the lab, that the patient can move seamlessly without needing a navigator. The patient should really be able to walk from the primary care physician's office down the hall to the oncologist's office, down the hall to the infusion center, and then down the hall to the lab and walk out without the need of a navigator. And that is what universal healthcare can provide, has the potential to provide, if only we let it, if only we remove these perverse financial incentives that has created this strange marketplace of profiteers that really suck the lifeblood out of the healthcare system.
Just a question. Can you achieve the same thing without it being in one building? Because that's how we got these consolidation of hospitals and all that with that idea. But can you say, yes, okay, I grew up in Gary, Indiana, so your private practice, it's in the community, they go there, you say, hey, oh, you got diagnosed with this, go there, and you quick phone call, you're coming, and it's the exact same thing, but do you have to be in the same?
No, this was a figure of speech.
Yeah,
all I meant was that the move from one place to the next needs to be seamless. You don't need pre-authorizations, you don't need gatekeepers, you don't need utilization reviewers, you don't need any of that. Go in, get seen, you need an oncologist, go down the street to the oncology clinic. Oh, you have cancer. Go down to the infusion center. Oh, you need a biopsy. Go down to the biopsy suite or whatever. You don't need to have pre-auth. And that is what many countries that actually have these systems in place have. If you talk to people from Germany, for example, they have no idea what a pre-auth is. They don't do that. They get a diagnosis, they get sent to the oncologist sees them, and they don't even see a hospital bill. You go to Australia. A colleague of mine was taken care of in Australia for a fall and a fracture. They anticipated a medical bill because they are used to what they got here. All they got was a $10 bill for the cab that took them to the hospital.
If I could on that piece, but and I agree with you, those are better systems. They are also very heavily regulated systems. The Australian government and the German government puts in place who can provide those services, what services they're going to. It's known, okay, what is covered already in advance, and they have a very heavy, which I'm in favor of. Don't get me wrong. I think that's the right approach. But our problem here locally is people would resist that because, again, it takes away a lot of individual choice.
The interesting thing is that we live in a heavily regulated society, sometimes even more regulated than those places. Seatbelt rules, for example, helmet rules, for example, the taxes that we pay. We are a very, very heavily regulated society. And the other piece of this is that the people who work in the healthcare arena, the physicians, the nurses, and the healthcare system workers are all very heavily regulated. We are under so many different rules and conditions. So when we think about regulation as being a barrier to us forming these teams, I think that's actually incorrect. We are already so heavily regulated. A little more regulation that helps me to survive is actually not a bad idea. Just like I wear a seatbelt in order to survive.
So I agree with that as the ideal, but there's so many impediments to that right now, right? Not the least of which is, EHRs, the fragmented health system, even within one building, because you have multiple employment models within that same system, really prevents, there's so much barrier for us that happening. But I love the question about how can we enhance integration with primary care right now? And I think there's something actually that we can do that doesn't require any of those things to be solved for. And that's to recognize that we have 19 million cancer survivors in this country, and those 19 million need specialized care due to ancillary effects of having been a cancer survivor, as I know you guys know. But they also have a much higher chance of getting a second cancer because they are a cancer survivor. So developing a strategy for primary care to have certification or specialized training to take care of these 19 million Americans who are cancer survivors, I think is something that we can do right now to improve health, to find those cancers earlier in someone who's going to develop a second cancer, and truly address the specialized needs of someone who has had a cancer diagnosis. So just as an opportunity to talk about a solution that's actionable now.
Yes,
so
actually,
I would like to, as the cancer doctor on the podium here, I would like to make a comment on that, which is there are not enough primary care doctors to do survivorship, and they are not trained in it, and the economic model of primary care has been trashed in this country. It's treat them and street them, and they can't possibly manage the complex questions that a patient has. So we look at cancer survivorship as an inherent part of the practice. And I think you've described my practice when you talk about you can walk down the hall and get everything. But two comments. The person who signs your paycheck on the front, that does not make care coordinated. Care coordination is when one doctor picks up the phone and talks to the next doctor and says, primary care doctor, I'm going to give this person steroids every 3 weeks for their lymphoma. They're diabetic. Please see them every 3 weeks and fix that before it gets out of control. And the only thing that I think Epic has done really, really well is it's made doctors and hospitals give one another their cell phones so they can actually communicate instead of going through all the rigmarole of trying to read through copious pages of notes.
Yeah, Barb, I think that, I totally agree with you on the bottleneck for primary care. But it's the case that for many clinics, oncology clinics, you don't have enough bandwidth to get new patients in early because patients who are 5 years out from cancer survivorship are still coming to the oncology clinic for routine care. Well, it's okay if you have bandwidth for it, but if you don't and you need somebody who has active cancer care to get in, it's a problem. So having a good handoff, I think, is an ideal, personally, I think we should go for.
So I want to interject here and build on some of the things you're saying, but refocus our next piece of the discussion on the cancer care disparities population, the folks who are not getting into care, the folks who are showing up to the emergency department with fungating masses or no health literacy around what a cancer could be and what it means. These are complex patients, typically. We know statistically that they are presenting at later stages. They have more complex socioeconomic circumstances. And they're going to be a shock to the system financially and in terms of navigation, coordination, a lot of the things that you've talked about. We've also talked about here different ways that we need to confront cost for cancer. And I want to ask all of you to do a little bit of a thought experiment. Say America said that cancer is special. This whole audience thinks cancer is special. Cancer is special, and we're going to cover things. And I don't want to dwell on how exactly, just for this question. We're going to cover cancer care. So if any healthcare provider is concerned about cancer and you just do the things, okay, you're going to get some patients who are getting their normal health care and have health care coverage, however you have it. You'll have some people who come into the emergency department, have something terrible, and kind of as they do now, and you'll say, okay, you've got cancer, we're gonna do the things. I would like this group to comment on how our system is or is not ready for those complex patients, and what a cancer benefit would have to do to take care of those patients effectively without overwhelming oncologists, primary care physicians, and and you know, how can we integrate all of those complex patients into our very piecemeal healthcare system?
I could start. What you're suggesting is the equivalent of refurbishing the top floor suite of a building when the foundation is weak. You have to start with primary care. Cancer diagnosis start at the primary care level. Very few patients go to an oncologist and say, hey, I have this fungating mass. Usually the patient is seen by a primary physician who does the investigation, does the biopsy, and refers them to an oncologist. So if you're to take care of that problem, you have to take care of it starting at the primary care level. Unfortunately, the primary care environment has been gutted. The primary care physician is not valued. Our young folks do not want to go into primary care. Less than 50% of graduating residents now in internal medicine actually end up going into primary care. Most of them go into subspecialty. And even that 50%, more than half of them go into hospital medicine. So that foundation is very, very weak. It is crumbling. It is being eroded every single day. And I think the likelihood is that the oncologists are going to be swamped more and more and more until that foundation in primary care is repaired.
And I 100% agree. I think that's what universal healthcare is about prevention and early detection. If that's where we spend our dollars, this is where we get the best return on our dollars. You know, in Washington, we have the Universal Healthcare Work Group, and they were talking about taking a look at savings. And they have their 2021 study found that if you have universal coverage through a single-payer system, that would save $5.6 billion a year in our state. And that's by cutting administrative costs, increasing the state's bargaining power, and reducing waste, fraud, and abuse. And so you have to make sure you are investing in covering every single human being for preventative care and early detection.
So, agree, but here's an uncomfortable truth. Even people who have coverage don't go for cancer screening. Even if they have a primary care physician, they're not getting the screening that they need. So I think that it's a yes and, totally agree with you on the weak foundation part. We have to get screening to people. That's one. So investing in innovation to get screening closer to home, we're getting there for some cancer screenings. That's certainly going to come. We have to do the things that can be fixed right now. We have a cancer vaccine for HPV-driven cancers. What is the uptake rate in the United States? It's a problem. We have an opportunity to end cervical cancer as we know it for everyone. We just choose not to do it. So I think we're going to have to address the motivation of the U.S. public to get into cancer screening. But I also think, lastly, we've got to think beyond, and this is, I'm chastising myself, right, as an organization that writes cancer screening guidelines and generally leads, and U.S. Prevention Services Task Force follows, is we have to stop thinking about cancer screening based on average risk population and your age. We have to start to incorporate the things that people know right now, sometimes their genetic background, their family history, their exposures, but also what happened on their at-home cancer risk testing. So I think integrating those into adaptable screening guidelines can identify the patients who are truly at high risk, who have to be prioritized for getting in for the colonoscopy, and they can't just be satisfied with the at-home screen. That's where we're going as an oncology community and as a cancer screening and prevention community. So the more that we get people ready for that, the better off we're going to be. And that will also help us to address a disparity we didn't talk about yet today, and that's rural populations.
Man, okay, so how can I say this? You know, we have never sat down and said, what do we need and how do we make it happen, okay? So I'm gonna break down a couple things. Number one, you're black in America, you go to the doctor, you're not treated like if you're white in America, period. In certain systems, if you're female, you're not treated like a male, right? As long as that exists, what we're talking about doesn't make any sense. I've had insurance my whole life, but it doesn't mean I get the care that I deserve and need and I want, right? So that's another point. Now, check this out. How many primary care doctors do we need in the state of Washington? Do we know that? Do we have them? Are we producing them? How many oncologists do we need in the state of Washington? Do we know that? Are we producing them? If we have the numbers, how do we set up a system that can interact with each other? For example, we tried to do this in Buffalo. We sat down with insurance company, primary care doctors, and urologists and said, how do we improve prostate cancer outcomes? They met for 6 years and couldn't come up with that. 6 years of arguing and fighting couldn't figure out how we put screening in place, how we put treatment in place, how do we put those things in place. Not to get, just who's paying for it, we don't even care. We're just trying to figure out what they're going to do. Right?
Exactly.
So we have to look at this very, very differently. Thirdly, I'm going to say this. I was working out this morning. I was listening to this motivational stuff. So Shantae Lowe's, look this up, YouTube. So she was a 4-time Olympian, all this stuff. She was 35 years old. She felt a lump on her breast, went to the doctor and said, I feel this little thing. And the doctor said, you're too young. Come back in 6 years. Turned out she had triple negative breast cancer. She would have been dead. Right? Black woman. So we can say what we want to say, but we got some real serious problems. So let's sit down and try to figure out how do we get the goal, reach the goals that we want to reach. Check this out, and I'm going to say this last thing. What happens if you're the coach of the Washington Huskies and you have losing seasons? You get fired. Right? But we had losing seasons when it comes to the health and the health of this nation in every single city, in every single state, and everybody gets to get up the next day with their jobs and go along with and their life. No, that's no longer acceptable.
If I could just, I mean, and there's a whole lot of layers to the problem, but don't move away from the fact that universal access would be an improvement. And, you know, as policymakers, and Manka said earlier, the more people who get covered, yes, some won't get screenings, yes, some won't get care. By the way, I don't know if it makes you feel any better, but I had massive mental health, physical health problems. I'm as white as the day is long. I got horrible treatment. Okay, it took me years to finally get a doctor who knew what was going on with me and had that conversation with me elsewhere. So it is a comprehensive problem that, yes, is much worse for people of color and elsewhere, but we got to look at it comprehensively. But I don't want us to lose track of the fact that there's no perfect healthcare system. I mean, at the end of the day, healthcare fails. We all die. Okay, so it's not going to be perfect, but don't walk away from the idea that if we had a universal access system, if everybody at least had the ability to go to a physician, that they were covered and they could do that, that would improve equity in cancer care. Because a lot of the people walking in who have the two, they had the problem for 5 or 6 years, and they said, well, I can't afford it. I don't have a doctor. I'm not going anywhere. And then you have an incredibly complex situation because they weren't treated up front. So, yeah, we can't make this perfect. Please don't walk away from the goal of getting to a universal access system. It would at least make that part of it better, even admitting disparities, 1,000 different other problems after that. But let's at least try to improve that for the people who simply don't have any access whatsoever, which is disproportionately impacting communities of color. So let's get to universal access.
I think I want to add something to that too, because I actually agree with you about the idea of not-for-profit health insurance companies, that I think insurance is a great idea. We all throw money in the middle of the floor here and hope the other guy gets leukemia and needs all that money, and we don't, right?
It's not just a great idea. It has to be done.
But
you can't
I
afford,
have had the opportunity in my own little practice as a self-insured practice. For the last 9 years in my practice, the cost of a premium for one of my employees has gone up $8. 3 years ago, I got rid of the copays on physician visits. 2 years, I got rid of copays on drugs. My premiums are flat. My max out-of-pocket is $2,000 a month or a year for a patient who is sick. And yes, we've had people, we had 2 ICU babies born on the same day. Get the odds of that. We have had patients with cancer in the practice. I've sent people to tertiary centers for brain surgery. $2,000 max out of pocket. It can be done if you structure it properly. And the fact that I have the ability to make this practice work in such a way that we do 15 to 20 same-day visits every day so that patients get the care they need when they need it by people they know and who understand their disease, you build that bond, that relationship. We can have those discussions. We don't have anybody die in the ICU at the end of their life. So it can be done. And one of the major impediments I found, even when people have insurance, is the copays and the deductibles, which is why I got rid of it. Why would you put a barrier of a copay particularly for my poor patients, or that my employees do fine, but for poor people, why do we put a barrier between what we want them to do that will improve their health to make it so that it's financially a disadvantage for them to do that? So I'll stop.
Thank you.
I
Thank
could go on forever.
Just to integrate an audience question and to reflect some of the really good personal experiences that have been described on this panel, some of folks in our audience who have worked in value-based care models have noted that it's doable with an intense team of professionals who are working together within a specific area. Sometimes they have smaller panels than really at-scale, large community practices. Sometimes, and so the question was, how do you reconcile the intensity of doing high-touch care and value-based care models, or whatever you want to call it? How do you reconcile that with the increased number of patients and the simultaneous physician shortage?
So it's team-based care, and it's everyone working to the peak of their education. It is having the physicians in the practice do what only a physician can do, which is going through the treatment choices and explaining the options and explaining the side effects and going through that and figuring out the patient's choice. But we can offload a lot of protocol-driven care to other people. When we do our same-day visits, those are done by my nurse practitioners and physician's assistants, who do a great job of making sure that pain is controlled and nausea is controlled and all the symptoms are controlled. And we have every person in the practice will take care of the person in front of them. We don't have nurses navigating. We have people who are appointment secretaries making sure that they can do all those things. You take a workforce and you maximize what they can do, and job satisfaction is really high. You give them a way to advance up a career ladder to be able to do more and more. You value them as a team that you could not work without, and we need to expand it. We have a physician shortage of 100,000 physicians in this country. We have to be able to work smarter. And I really am hoping that some of the AI systems, as we get this tsunami of information that's coming across our desks every day, to be able to sort through that information and help me work smarter by pulling that information out and delivering to me at the time I'm seeing a patient exactly what I need to know about that patient. And let me tell you, the EMR is not it.
All right.
So can I just add to that, because Washington is trying to move to doing more and more value-based care, but that financial incentive in doing a model that everyone agrees that we should be doing value-based care, like taking care of the whole patient in a holistic way, the financial incentive is not there to have everyone switch to this model. And until we can address that financial incentive that people have in doing a lot more procedures and doing a lot of expensive interventions, we're not going to be able to get to this model, which I have heard over and over again everyone wants. But we need all these smart people to figure out how we address that financial incentive to not do early intervention.
We should just get rid of fee-for-service, period.
Oh, I disagree entirely, especially with a shortage of physicians, that it's human nature to want to do a little bit more if you see that there's something in it for you. I'm sorry, but we can't change human nature, even if I couldn't get elected saying that. And so if you want to have a physician that is just on a salary, why should I stay after 5 o'clock to see a patient just because she's been told she has breast cancer and she needs to be talked off the ledge? You know, you need to make it so that you give an incentive for people that they want to work harder, they want to work smarter, they want to be able to see the patients that need to be seen. And I also think that value-based care is, I'm an advocate for value-based care, but I want the value to go to the patient, not to the insurance companies. And what I'm seeing is that it's now switched over to the value goes to saving money for Medicare. That's why I'm not an EOM.
So when I say we move away from fee-for-service, I didn't mean that everybody just gets a salary every month and sleeps on the job. What I meant was that our practices stop being reimbursed for the widget, the face-to-face, the poke, the prod, the stick, that we do to the patient, but we get reimbursed for the overall care of the patient. We are still incentivized to work hard. We are still incentivized to take good care of our patients, but we should stop this madness of fee-for-service. Perfect example would be a patient who has cancer and has received chemotherapy and has cancer-related cardiomyopathy. This patient may need an adjustment of their diuretic dose, for example. In a fee-for-service environment, that diuretic dose cannot be adjusted until and unless they come to the clinic. Okay? There's a shortage of physicians, et cetera, et cetera, et cetera. That's time that a physician could have been using doing other things. A nurse could have made that phone call and told the patient, take double your dose of Lasix. So when we're talking about people functioning to the highest level of their practice capability, we're talking about innovating and using efficiencies to produce better outcomes for patients. That's what I'm talking about. And fee-for-service is perverse and does not allow us to do that.
Thank you.
Agreed.
Disagree.
You know, so I'm listening to this, and other stuff comes to mind. I say, yeah, so you get surgery, you know, you say, well, you know, you covered for the next 3 months after that surgery, then all of a sudden you're not having that person come in every time to follow up, to look at that wound and all the stuff as you probably should, right? So we have to sort of think of the pros and cons as we lay these things out. So I'm not sure if we need fee-for-service or some other model, but I'm just trying to figure out, hey, how do I get this individual who's at high risk for prostate cancer to get a PSA, right? To get a digital rectal exam, to get a biopsy if their PSA is elevated, and to sit down with a competent person who says, hey, here are the options, and here are some things I want you to consider, and that person gets the treatment that they need in a timely manner. What's what I got, all right? So they could go on and be there 12 years later, 20 years later, for their family. The same thing with bladder cancer, breast cancer, colorectal cancer. And some of this stuff, when I'm hearing it, I'm not really sure that we're making a step to that place.
Yeah,
right?
can we pull on the prostate cancer thread for a second? Because this is a really big one, right? This is the biggest disparity that exists in all of oncology, right? Black men 70% more likely to be diagnosed, 2 to 4 times more likely to die of their disease than any other demographic. I don't know what you call that, but I call that unacceptable, right? Mm-hmm. And at the same time, we know that this is a disease for which we absolutely can cure early stage disease. Not everybody's going to need to be treated who's diagnosed. We've moved on as a field, though we can cure those. I mean, we know unequivocally we have no durable cure for metastatic disease. Ergo, there's only one solution. People have to get screened. And in this case, the fact that people aren't is even more unacceptable, because I know the DRE is really important, but if you can get somebody to just take the blood test and then determine, are you at risk for having developed prostate cancer, that's something, I'm going to get back to what I said before, you can do at home. And that is where innovation is going. And that will also allow us to allow the patients who do, unfortunately, present with metastatic disease get the care that they need very quickly, because someone else has been diagnosed early, giving them an opportunity to save their life, but also reduce costs for the system. PSA for HIMSS Act, coming to you soon, Representative.
So, lots of great discussion, really complex problems, and lots of different handles from which we could kind of grab on and do something. As we come up on towards the end of our time, I do want to focus us in on potential solutions, and not just pie-in-the-sky solutions, but I want you to think about your sphere of influence, lawmakers, heads of large organizations with a lot of arms, physicians. I want you to think about what can we do, what changes can we make in the next 5 years that could improve access to timely care for cancer patients. I would like to also raise the elephant in the universe here for cancer care, which is cost of drugs, and the concept of a cost ceiling for cancer, and that we're going to have to confront that as a society. But instead of just focusing on cost, I would like to go through and have everyone share what, from your professional sphere, what do you think needs to be done to take a step in the right direction in the next 3 to 5 years?
Do you want us to go down the list?
Okay. 2 big things. One, I'll go back to, I think, what Karen said at the start. expanding access matters. And we can all dream of, what if we had Germany's healthcare system or whatever, but I think what we learned over the last 30 years is the difficulty of doing that, but the importance of expanding it. I think it's 7 million people who are uninsured prior to the ACA, 7%. Prior to the ACA, it was 14 or 15%, okay? That's, 30 million people now who have better access to care. What if we got that 7% down to 4? Okay, so expanding access matters. And the only other thing I would say is to your point, sir, about the physicians who got together and tried to figure out best practices for prostate care. That's a real problem within the medical profession. And I encounter this dealing actually with mental health. I had an anxiety problem. But as I went through, a dozen different psychiatrists and trying to figure out what was going on, there is a best practices approach. Don't have time to get into all of that now. But within the medical profession, if there was more of a willingness to give us policymakers that answer, okay? And I know it's tough because everyone's got a different opinion. And, when you look at mental health therapy, you got psychiatrists, they're doing their thing off here. But there are things that work better. And if we knew what those things were, we could then get to that off of fee-for-service. We could pay for quality. We could say, this is what works. We're going to pay more for it. We're going to incentivize you to do it. So those are the two big things. Get more people covered, get a better idea of what best practices is so that we know what is worth paying for. Sorry, not worth paying for. What is better to pay for.
So again, access is number one, and that access starts with access to primary care services, but also a coordinated and functional integrated healthcare team or team-based care. I think payment reform is a very important issue. The American College of Physicians has supported and is advocating in Washington, D.C. right now, and hopefully maybe we'll be advocating in this Washington, for payment reform and moving away from fee-for-service to some of these more innovative payment solutions. I don't think there is one particular system that will fix everything, single payer versus multiple insurance companies, private health insurance. Some kind of payment reform needs to be made both from the physician practice level, but also all of the other different levels of the healthcare system. I think there also needs to be a focus on quality improvement and innovation. We have a lot of people who work in healthcare, physicians, nurses, et cetera, who are very smart and who can innovate and who can figure out a way to get to that patient who needs that prostate cancer screening who has not been screened. One of my residents simply put in an alert on the EHR. They built a little alert on the EHR that simply flagged certain patients who were due for a screening evaluation, and that actually increased the screening rates almost by 50%, a very simple fix. That was not covered by fee-for-service, by the way. And then finally, I guess, finally, the other thing that I want to sorry, I've lost my train of thought. Basically, improve access to primary care would have been my biggest focus.
Well, so I'm going to ask this question. What happens if we improve primary care access, and I'm going to stick with prostate cancer, and we diagnose more prostate cancer, but we don't have urologists and medical oncologists to take care of them? We diagnose more cancer, but we haven't improved our outcomes, right? Part of what I see is that we actually truly haven't really figured out what we want, right? So we do not have a declaration of health and a constitution of healthcare. Like, what does it really mean to improve the health of this nation, right? Not actually just the health care, but the health of this nation, because we cannot reduce costs until we improve health, right? So this is what we actually, I think we should do. We got a lot of smart people, right? We have payers, we have physicians, we have entrepreneurs, we have all these sort of things. And if we really set out, we got Barbara, she rocks, right? We sit down and say, hey, let's come together and let's really figure this out. What does it mean to have a healthier nation? And then put everything, utilize our $4 trillion around that. Because everything we talked about as things popping in all would be a part of that, and I believe we can agree upon that, right? So that's sort of what I think over the next 5 years we should be doing.
Dr. Underwood, just to follow up there, so are you talking about sort of a think tank approach? I mean, you're talking about CMMI and the National Academy and
I'm talking about a think
professional
tank
associations. I mean, who?
I'm talking about everybody. a think tank approach. Okay, I'm gonna just quickly. So Steve Jobs walks in the room and he says, I want 1,000 songs in my pocket with 100 people, right? 1,000 songs in your pocket. There was none of this Apple Music, none of that stuff existed, right? He just focused on, I want a device that's small enough to put 1,000 songs in my pocket, okay, to solve a problem. What problem are we trying to solve? And let's focus on resources on solving that problem. The problem we're solving is that we have a sick nation that we spend $4.3 trillion a year on, and we're still sicker than everyone else. That's the problem. So when we say let's address that, that's not insurance. That's making the nation healthier. Then we will pay for what we need to pay for, not pay for things that we don't need to pay for, and we will have children growing up in a society wanting to be healthy and living their best life.
What you're calling for is a moonshot.
No.
Not the moonshot. So I agree with Willie. I never disagree with Willie. So we've been friends a long time. But I think that if we're going to address the fact that the inequality of the delivery of health care across our nation is hurting people, that people based on their zip code have a 20% lower outcome for their cancers, that has to be addressed. And the way that I would address it immediately, if I had control of Congress, but no one has control of Congress, but if I did, I would get rid of the geographic price cost indicators, and I would stop figuring out we have a national market for when I hire an oncologist, I don't put an ad in the Gallup Independent newspaper, right? It's a national market. We need to get rid of that, and we need to recognize that it costs more to deliver care to people who have less resources of their own. We need to flip the idea that we pay more in richer areas and less in poor areas. I would stop the consolidation of the healthcare system. The FTC is working on it, DOJ is working on it. There is good literature that shows that when you consolidate hospitals into hospital systems, quality drops, price goes up, access goes down. We need to stop that. And I would I would want to change the way the Medicare Advantage plans are doing and stop letting commercial companies profiteer off Medicare, because they are making a fortune doing this. And I would stop it, and I would investigate it now. And I would get rid of the pharmacy benefit managers, because in working for my governor on the task force for drug pricing, we figured out that we could drop the price of drugs by almost 50% by getting a flat fee pharmacy benefit manager and stop letting them profiteer.
So I'm going to take us back to the first question you asked when we sat here. And I said, each and every person in our society deserves high-quality health care regardless of their ability to pay, right? We have these ideals and what we want the society to look like. And the question then again is, how do we get there? And I think what we have heard in the last hour and a half, that is extremely complicated with a lot of barriers. But to your point on putting people together to develop these systems, I'm really proud of the fact that in 2019, Washington State Legislature established a universal healthcare work group, really making sure we're setting that foundation to get us to where we want to go. We still have to implement parts of it, but at least there is a vision and a plan on how we're going to get there. In 2021, we established a Universal Healthcare Commission. I think you guys are hearing from them today. But even in terms of taking a look at cost of drugs, in Washington, we have capped a lot of our medications, prescribed prescription drugs, to make sure they're affordable. And, we actually in 2021 passed legislation that enables our state to partner with manufacturers or other states that are producing their own generic drugs. Not an ideal situation, but that's what we've done. And states like California are setting up production programs, which I think is going to be interesting to see how these options play out. And one of the other things that we've done in Washington that I'm really proud of is actually making undocumented immigrants eligible to purchase healthcare insurance. The state's paying for care anyway, but let's make sure people who want to purchase insurance can do that regardless of their immigrant documents status. I'll stop there. But I think we have to work on all aspects of this at the same time. And I'll just say Washington is one of the most consolidated states in the country when it comes to access to health care. And choice in health care that everyone wants, it's illusionary, is what I'll say. People think they have choices, but a lot of Americans do not have choices.
So I really agree with my colleagues' great ideas here. I'm not going to repeat what I said at the beginning because I think I came out with my ground shots in the 5-point plan. So what I'm going to do is I'm going to tell you what I am going to do. I am going to continue through our organization, which has operations in all 50 states, Puerto Rico, and Guam, to enhance access to care. We have 32 Hope Lodges where we house cancer patients and families free of charge so they can get to the centers that they need to get to care. We give more than 250,000 patients rides every year so that people can get back and forth to care. I'm going to continue to do that. But I'm also going to continue to have significant advocacy priorities. I don't know if you read the news yesterday, but I'm going to continue to put my thumb on the Biden administration to finalize the rule to eliminate menthol cigarettes and flavored tobacco. If we want to make a dent in cancer disparities and cancer incidence, we have to do that. At the federal level, I'm also going to continue to push for the Diverse in Cancer Trials Act, for the PSA for Him Act, as well as MCEDS. Now, MCEDS, we still have a lot of work to do, but laying a pathway for reimbursement so that then when they become shown to improve life and to have clinical benefit, that there's a pathway to reimbursement so more people have access to it. At the state level, I am going to continue our advocacy on Medicaid expansion. We've turned 40. We're going to get after those additional 10. And I am also going to continue our march across the country on the Biomarker Reimbursement Act, requiring state plans to cover biomarker testing for cancer patients so that they get to the right drug the first time, which saves lives and reduces cost. We've got 17 states now to sign this into law, most recently Indiana just a couple of weeks ago, and that's after a year and a half of advocacy. So what I invite all of us to do and think about is how we can work together to get these things done, to focus on national priorities like the real concern that is prostate cancer for all men, but especially black men in the country, and I'd invite anyone to join forces with us. Thank you.
We are late, though, so I'm going to rapidly go through this because we need a full 15-minute break to change the stage. So thank you, everyone. Please remember to complete the post-activity evaluation on our education portal, education.benetfoundation.org. CME credits are also available. And a big thank you to industry for supporting this. And also, if people want to get involved, there are ways to get involved with the foundation to support the hospital in Nepal, as well as the journal, please connect. Thank you. So we're back at 10 of.